Welcome back to the deep dive. Today, we're heading into the operating room, metaphorically speaking, to tackle a really serious issue: surgical site infections, or SSIs.
And we're leaning heavily on the absolute gold standard here, the clinical practice guidelines for antimicrobial prophylaxis. This is a huge collaborative effort from groups like ASHP, IDSA, SHE, SS, basically the leading voices in pharmacy, infectious diseases, and epidemiology.
Right, these aren't just casual suggestions, they're based on hard evidence.
Exactly. Ironclad rules, really, designed to keep patients safe during surgery.
So our mission today is to unpack why these rules are so specific, particularly around primary perioperative prophylaxis that's preventing the infection right when the surgery happens.
It needs that rigor because, honestly, despite all our modern techniques, SSIs are still a major, major problem. They cause significant harm, keep people in hospital longer, and sadly, they can be fatal.
Okay, let's start right there. Why so much focus? Paint the picture for us. What are the real stakes here?
Well, first off, the sheer number. SSIs make up about 20% of all infections people get in the hospital. Think about that, 1/5.
20%?
Wow. And if a patient develops an SSI, their risk of dying jumps dramatically, anywhere from 2 to 11 times higher.
That's a huge range, but even the low end is alarming.
It is. And here's a really stark statistic. For about 75% of the deaths linked to SSIs, the infection itself is the direct cause. It's not just a contributing factor, it's the killer.
Okay, so the clinical impact is devastating. What about the financial side? I imagine that's pretty significant too.
Oh, absolutely enormous. In the U.S. alone, the estimated cost is around $3.3 billion per year.
Billion, with a B.
With a B, just managing these preventable complications. And for an individual patient, an SSI adds, on average, almost 10 extra days to their hospital stay.
9.7 days, the guidelines say. That's a long time.
It is, and it jacks up the cost of that hospital admission by over $20,000.
20 grand extra, just because of the infection. You can see why hospitals are focused on this. Is it a similar story elsewhere, say, in Europe?
Very similar. There was a big study in Germany, looked at 79 hospitals. They found an overall SSI rate of about 4.9%.
Okay, roughly 1 in 20 surgical patients.
Yes, and look at the outcomes. The death rate for patients with SSIs was 9.3% compared to just 4.5% for those without.
Double the mortality risk again.
And the length of stay. Median was 28 days for SSI patients versus 12 days for others.
More than double the time in hospital.
And the cost difference was stark there, too. Median cost for an SSI case was over $19,000 compared to about $9,000 without an SSI.
Almost double the cost.
And critically, that study found hospitals were often losing money on these cases, an average underfunding of over €1,500 per patient, because the care needed was so much more complex than the standard reimbursement covered.
Right, so if you connect all those dots, the human cost, the financial burden, the strain on the system, it just screams why these prevention guidelines have to be followed to the letter. There's just no room for error.
Precisely. That financial pressure, combined with the clinical imperative, is what drives the need for such rigorous adherence.
Okay, let's unpack that rigor. Starting with maybe the most talked about rule, timing. Getting the antibiotic in at the right moment. It's all about kinetics, right? Having enough drug in the tissue when the incision happens.
Exactly. Timing is everything. And the rules have gotten much tighter over the years. It used to be kind of vague, give it around anesthesia induction. But the current standard is crystal clear. Administer the dose within 60 minutes before the surgical incision.
60 minutes, 1 hour. That sounds challenging to manage in a busy OR. Is that 60-minute window a real pressure point?
It absolutely is, because the evidence is just unforgiving. Studies clearly show the infection risk shoots up if the antibiotic is given too early, like hours before, or too late, meaning after the incision's already made.
The drug concentration has to be peaking right at that moment of maximum risk.
That's the goal. You need those therapeutic levels right then and there.
What about drugs that need a longer infusion time? You can't always get them in within 60 minutes.
Good point. That's the main exception. For agents like vancomycin or fluoroquinolones, which need that slow drip, the rule is you have to start the infusion within 120 minutes before the incision.
So 2 hours. Giving enough time for the infusion to finish and the drug levels to get where they need to be.
Exactly. So by the time the surgeon actually makes the cut, the protection is there.
Okay. Timing sorted. What about the other end? How long do you keep giving the antibiotics after the surgery? I hear that's also changed quite a bit.
It really has. The big push now is for much shorter durations. The recommendation is strongly in favor of either just a single dose, given preoperatively,
Just the one dose.
or, if needed, continuing it, but for less than 24 hours post-op.
Less than 24 hours. Why the clampdown? Is it purely about saving costs, or is there a clinical reason?
Oh, it's definitely clinical. It's driven by antibiotic stewardship and patient safety. There's a serious risk trade-off.
What's the risk?
Giving antibiotics for longer than necessary or using multiple agents when one would do significantly increases the patient's risk of developing other problems. The big one is Clostridium difficile colitis.
Ah, C. diff. Nasty stuff.
Extremely nasty. A severe, sometimes life-threatening infection caused by disrupting the normal gut bacteria. So, stopping the prophylaxis quickly helps protect the patient's microbiome and reduces the chance of breeding antibiotic-resistant bugs.
Makes sense. So get in, protect during the highest risk period, and get out quickly. But what if the surgery itself is really long, say many hours? That initial dose won't last forever, will it?
No, it definitely won't. And that's where redosing comes in. This is crucial but sometimes overlooked.
Right.
Intraoperative redosing is mandatory if the procedure duration exceeds 2 half-lives of the specific antibiotic being used.
2 half-lives. Can you give us an example? Cefazolin is common, right?
Right. Cefazolin is the workhorse. Its half-life is roughly 1.9 hours. So the practical rule is you need to give another dose about every 2 hours during a long surgery.
Every 2 hours on the clock.
Approximately, yes. And there's another trigger for redosing, excessive blood loss.
Ah, okay. How much loss?
The threshold is usually cited as more than 1,500 milliliters. If the patient loses that much blood, they're also losing the antibiotic that was circulating, so you need to replace it to maintain those protective concentrations.
That level of precision around kinetics is really something. Okay, let's shift from the clock to the patient themselves.
Yeah.
Adjusting the dose seems like a big focus now, especially for obesity.
Yes, that's a major update and a really important one. Obesity is a significant independent risk factor for SSIs.
Why is that? Does fat tissue make infections more likely?
It's more about pharmacokinetics again. Standard antibiotic doses often don't achieve adequate concentrations in obese patients, especially for hydrophilic or water-soluble drugs like cefazolin.
So the drug gets sort of diluted in the larger patient.
Exactly. You have a larger volume for the drug to distribute into, both water and fat, so the concentration at the surgical site can end up being too low subtherapeutic. It just won't be effective.
So you need to give more. How much more?
The guidelines are quite specific for cefazolin. For patients weighing over 80 kilograms, the dose should be increased to 2 grams.
Double the standard 1 gram dose.
Right. And for patients over 120 kilograms, it should be boosted even further to 3 grams.
Triple the dose. That's a significant adjustment. It sounds like they're really trying to personalize the approach.
They are, and it goes beyond just weight or BMI. While a BMI over 30 is the usual definition of obesity, there's growing evidence that body fat percentage might actually be a better predictor of SSI risk, like over 25% for men, over 31% for women. It might give a more precise picture of the physiological challenge.
Interesting. So moving towards more tailored risk assessment. Now let's talk about the bugs themselves. The main culprit is usually Staphylococcus aureus. Right?
That's the big one. S. aureus accounts for around 30% of all SSIs.
And a lot of people carry it normally, don't they? In their nose.
That's right. About 1 in 4 people are nasal carriers of S. aureus. And being a carrier significantly increases your risk of an SSI, maybe 2-fold, maybe up to 14-fold, depending on the study and surgery type.
Which brings us to a really key drug, and a controversial one, vancomycin. Given that S. aureus is so common, and MRSA, the resistant form, is a concern, why isn't vancomycin used routinely for prophylaxis?
Yeah, that seems counterintuitive to many, doesn't it? If S. aureus is the main enemy, why not use the big gun?
Exactly.
But routine vancomycin use is strongly not recommended. There are a couple of big reasons.
Right.
First, for most surgical populations, vancomycin actually hasn't been shown to be more effective than standard agents like cefazolin, even with MRSA prevalence. And second, it's a crucial stewardship issue.
Protecting the drug for when it's really needed.
Precisely. Vancomycin is one of our last lines of defense against serious MRSA infections. Overusing it for routine prophylaxis just speeds up the development of vancomycin resistance, which would be catastrophic. We risk losing it altogether.
So when is it okay to use vancomycin for prophylaxis?
Only in very specific high-risk scenarios. If a patient is known to be colonized with MRSA.
Okay, documented carrier.
Yes. Or if there's a known outbreak or cluster of MRSA infections within the hospital or institution impacting that surgical population. Or sometimes in specific high-risk patient groups where the consequences of an MRSA infection would be particularly dire, but it's definitely not the default.
So if routine vancomycin is out, But as psoriasis is a problem, what else can be done? You mentioned nasal carriage. Is there a way to deal with that before surgery?
Yes, and this is a really important adjunct strategy. Decolonization.
How does that work?
It involves screening patients preoperatively, often with a nasal swab, to see if they carry S. aureus, particularly MRSA. If they do, they can be treated to reduce the bacterial load before surgery.
What kind of treatment?
The most common approach is using an antibiotic ointment called mupirocin inside the nose for several days leading up to surgery. This is often combined with using special antiseptic washes like chlorhexidine for bathing.
And does that actually work? Does it lower infection rates?
The evidence is quite strong that it does, especially for certain types of surgery like cardiac or orthopedic surgery, where S. aureus infections are particularly devastating. Studies have shown significant reductions in SSI rates, sometimes cutting the risk dramatically.
Like that study you mentioned earlier, dropping deep SSIs from 4.4% down to 0.9%. That's huge.
It is, just from adding that targeted decolonization step for carriers.
Okay, one more drug question before we broaden out.
Blech.
What about allergies? Beta-lactams like cefazolin are the mainstays, but lots of people report penicillin allergies.
That's a common challenge. A documented true Ig-mediated allergy, the kind that causes anaphylaxis or hives, means you absolutely cannot use cefazolin or related cephalosporins.
So what's the alternative then?
You need a different regimen. Typically, this involves using either clindamycin or vancomycin, but crucially, those drugs mainly cover gram-positive bacteria like staph. So, depending on the type of surgery and the risk of gram-negative bacteria, you often need to add another agent that covers those, like a fluoroquinolone or aztreonam. It gets more complex and requires careful selection.
Definitely need an expert pharmacist involved there. Okay, let's pull the lens back a bit. Antibiotics are key, but the guidelines make it clear that SSI prevention is about more than just drugs. What other factors play a big role?
Oh, absolutely. It's a whole bundle of care. Patient factors are huge. Things like age, how well nourished they are, obesity, obviously, whether they have diabetes, if they smoke, or have any condition that weakens their immune system.
All things that can make someone more vulnerable.
Exactly. And then there are procedure-related factors. The surgeon's own technique and experience, how long the surgery takes, and really importantly, how well the patient is managed during the operation. Things like keeping their body temperature normal and controlling their blood sugar levels tightly.
Right, temperature and glucose control. They seem like basic nursing care, but why are they so critical for preventing infections?
Well, if a patient gets cold during surgery, hypothermic, their blood vessels constrict. That reduces blood flow to the incision area.
Which means less oxygen.
Less oxygen, fewer immune cells getting to the site, and crucially, lower concentrations of the antibiotic reaching the tissues where it's needed. It undermines the prophylaxis.
Okay, and high blood sugar.
Hyperglycemia, or high blood sugar, directly impairs the function of neutrophils, key immune cells that fight off bacteria. So if blood sugar is uncontrolled, the body's own defenses are weakened right at the surgical site. Managing both temperature and glucose is fundamental.
Does the type of surgery matter? Like minimally invasive versus a big open operation?
Absolutely. Laparoscopic or other minimally invasive approaches generally have significantly lower SSI rates compared to traditional open surgeries.
Makes sense. Smaller incisions, less tissue trauma.
Precisely. We see it in the data, like laparoscopic gastric bypass might have an SSI rate around 0.4%, while the open version is closer to 1.2%.
Triple the risk for the open procedure.
Yeah, and the guidelines reflect that. For example, for gallbladder removal, low-risk patients having an elective laparoscopic procedure often don't need antibiotic prophylaxis at all.
No antibiotics.
Not routinely needed if it's straightforward and low risk. But if it's an open procedure or the patient has higher risk factors, then prophylaxis is definitely recommended.
So the approach really dictates the strategy.
Yeah.
Now, all these rules, timing, dosing, duration, glucose control, they sound great, but how do we make sure they actually happen consistently? Are there systems in place?
Yes, thankfully. It's moved beyond just guidelines on paper. Initiatives like the Surgical Care Improvement Project, SCIP, really formalized this.
SCIP, I've heard of that.
It built on earlier efforts and created a standardized set of quality measures. Hospitals have to track and report their performance on things like, was the right antibiotic chosen? Was it given within the 60-minute window? Was it stopped within 24 hours? Was glucose controlled? Was temperature managed?
So making best practice measurable and mandatory.
Exactly. It creates a checklist mentality, in a good way, to ensure all the critical prevention steps are followed for every patient, every time.
And is there teeth behind these measures? You mentioned the financial strain earlier. Is compliance linked to payment?
Increasingly, yes. That's the big lever now. Performance on these SCIP measures and similar quality metrics is often publicly reported. Patients can actually look up hospital scores online.
Ah, public accountability.
Right. And more, these metrics are tied to financial incentives through pay-for-performance programs. Hospitals that meet the standards might get bonus payments, while those with poor performance can actually face financial penalties or reduced reimbursement.
So quality care becomes directly linked to the bottom line. That's a powerful motivator.
It really is. It aligns the clinical goals with the financial realities of running a hospital.
Okay, so wrapping this up, the key message seems to be that preventing SSIs is this incredibly precise, high-stakes process. It demands strict adherence to rules about timing that critical 60-minute window dosing based on weight, keeping duration short, usually under 24 hours.
Alongside managing all those other factors like
Yep.
temperature and glucose?
Right, and all this intensity is driven by the really severe consequences, both clinically for the patient and economically for the healthcare system, if an infection does happen.
That really captures the current state of play based on the guidelines. But, looking ahead, it's not like we've solved everything. There are still gaps in our knowledge.
Which leads to maybe a final thought for you, the listener. Given that we're still facing challenges like antimicrobial resistance and hospitals are under constant financial pressure, how do we move beyond just following the current rules to truly optimizing care?
Yeah, that's the big question. Because even with these detailed guidelines, we still need better answers on some things. Like, what are the ideal target concentrations of antibiotics we should be aiming for in the tissue itself? Can we develop ways to monitor that in real time during surgery?
Real-time feedback. That would be a game changer.
It would. And what's the absolute best strategy for screening and decolonizing patients, especially for resistant bugs like MRSA? Should be universal, targeted. We need more clarity. And how much impact do these quality measures and financial incentives really have on outcomes?
So it really highlights that constant tension in medicine, doesn't it? Trying to provide the absolute best, safest care for the individual patient right now.
While also safeguarding our tools, like antibiotics, and managing resources wisely for the future. It's a continuous balancing act.
A balancing act that defines so much of modern surgical safety. Well, that's all the time we have for this deep dive. Thanks for joining us.